we're getting back towards 2 minutes. Can we please charge the defib again, please?
Compressions continue, everyone else away, oxygen away, charging, top, middle, bottom clear, hands off compressions.
Okay, that is still asystole. You've dumped the charge.
Charge done.
And can we continue with CPR?
You found 2 categories that people won't survive CPR. Can you tell me about those?
I identified 2 categories. One, patients who are actually dying, and the second category are patients who are not dying but are very frail and fragile and we know would not survive CPR. If you perform CPR for these patients, it merely converts a gentle dying into a bad dying.
So for those who are dying, it wouldn't seem sensible to be talking about CPR. How should we approach this conversation?
I don't think this is a discussion about CPR. I think this is a discussion about dying, explaining what normal dying looks like.
In the category where they're unwell and not likely to survive, but they may not die on the ward as well, so it's not imminent. How do we approach this group?
This is a discussion about CPR. It's a discussion about how unwell the patient is and making sure that there's an understanding that the patient might have a cardiac arrest because of their unwellness, and if that happened, we wouldn't be providing CPR because it could not be effective.
What might seem to the doctor to be a simple and rational and medically responsible decision can be challenging for the family because if things don't work out, they may have lost a loved one, and they will always ask the question about what their role and responsibility is.
Okay, Vicky, so I think I've done the 4 H's. What about the 4 T's? So we've done tension pneumothorax, tamponade, temperature, and thromboembolic. We just check her legs just to see if there's any evidence of any DVT or anything.
If we move to the patients that may survive CPR, and I understand on a medical ward it's between 0 and 18%. We've talked about the 0% group. What about those who are quite frail, not that unwell, but we think they're likely to have a pretty poor outcome? How should we approach the discussion with this group?
This is a group where CPR may be appropriate, but we would generally be recommending that we don't provide CPR because here the risks of harm and in terms of dying during CPR or having impaired function afterwards start to outweigh any potential benefits.
So when you look at the statistics and only 2% would have survival at a reasonable functional level, I guess it's really important to make sure that the goals of the patient have been clarified. Are they prepared to take this risk? Because those odds for many will be unacceptable.
That's right. Although some people will have a different way of valuing CPR and may choose to take those risks and say that's okay for them.
And the 4th category are the group who, again, are going to have a fairly poor outcome. Maybe they've got a 5% or 4% chance of surviving the level of function they start with.
These patients I think it's a discussion like any other high-risk medical treatment, discussing the benefits and burdens of CPR or no CPR in a way that makes sense to the patient's context, not just the statistics, but helps them to understand what those outcomes could be. And we should arrive at a shared understanding of what's going to be best for the patient.